Good afternoon, everyone, and thanks for being here. It's a real pleasure to welcome Professor Christopher Byrne to our institution today. Chris trained as a physician and clinical scientist between the UK and the US, with time at Cardiff, Cambridge, and Stanford. And he is now a metabolic physician at the University Hospital of Southampton. He's built his career around metabolic liver disease, dyslipidemias, and type 2 diabetes, and is a principal investigator at the NIH Southampton Biomedical Research Center. Over the years, he's made major contributions to understanding the causes of MASLD, consequences and treatment strategies, publishing widely and collaborating internationally. Today, he's going to talk to us about the links between MASLD, cardiovascular and kidney disease, and the new treatment options coming through. A highly relevant topic for both clinical and research settings. So without keeping you any longer, please join me in welcoming Professor Byrne.
Pablo, thank you very much for the kind introduction, and thank you to you and your team for giving me this opportunity to talk to you this afternoon. So I'm going to talk about MASLD, cardiovascular disease, CKD risk, and I'll touch on treatments towards the end. And I have to credit a lot of other people, and particularly with regard to talking to the Italian Federation, my close friend and colleague Giovanni Targia from Verona and Alessandro Mantovani, and they must take an awful lot of credit for this presentation as well. So what I'm going to do is I'm going to, my slides, they were going forward a couple of minutes ago. There we go. My disclosures, research grants from Ecosens that's relevant. And I'm going to talk about NAFL, MASL, residual risk in type 2 diabetes, NAFL and MASL as a multi-system disease, and us proposing this back as long ago as 2015. And I think it's become an accepted mantra now that NAFL or MASL has consequences beyond the liver. I'll briefly touch upon the new nomenclature and the importance of metabolic dysfunction, because that's very relevant to some of the unpublished work that I'm going to present to you towards the end of this presentation. I'll talk about diagnosing liver disease particularly and how that's changed over the course of the last decade. And I'll talk about the utility of the metabolic syndrome traits and our recent insights, some of which is published, and as I say, some of which is unpublished from UK Biobank. And then towards the end, I'll talk about new treatments that are coming online. And I think that the whole field will really be revolutionized over the course of the next few years, not least with the incretin receptor agonists that I'll talk about, that people like myself as diabetologists have been using since 2005, when they were first launched as exenatide as the first agent for type 2 diabetes, but now proving very useful in the management of obesity and also in helping patients lose weight and benefit MASL. So look at the right-hand slide. These are the 2023 criteria for diagnosing MASL, as we're calling it now. And it's really important in thinking about these criteria. And when we were putting this together in 2023, there was an awful lot of debate and certain controversy as a number of us as diabetologists, 4 of us from around the world, got together and were advising the liver group on what should the metabolic abnormalities be for defining metabolic dysfunction in MASL, and indeed what the thresholds should be and how many of these particular criteria should be needed to assign a diagnosis of MASL in a patient with steatotic liver disease. And I have to say, after a lot of quite vigorous debate, we decided upon one criteria. And I think that opens up and begs the question then as to whether, if a patient has all 5 of these metabolic criteria that define metabolic dysfunction, are they worse off with respect to their future risk? And I'll show you some of our recent data where we've looked at answering that particular question. Now, I started as a diabetologist. In fact, I am practicing clinical diabetologist here in Southampton and look after a lot of patients with type 2 diabetes and cardiovascular disease, some of whom have MASLD and others of whom don't have MASLD. And we've known about cardiovascular disease as a major cause of morbidity in people with type 2 diabetes. We have about 5 million now, 4.5 to 5 million people in the UK that have diabetes. And about 90% of those will have type 2 diabetes, and about 1 in 3 of those patients with type 2 diabetes will have evidence of cardiovascular disease. And in the UK, type 2 diabetes in particular is associated with about 10% of all cardiovascular deaths. However, it's really important to recognize, even with conventional treatments such as statin treatments that we've been using for the last 20 years to reduce cardiovascular risk in patients with type 2 diabetes, even using recognized agents such as atorvastatin, a very powerful statin that I'll use all the time in the clinic in my patients with type 2 diabetes, where I can get an approximate 40% reduction in residual risk with a statin versus placebo in my patients with type 2 diabetes. It's really important to recognize that there is still an awful, regardless of whether you use simvastatin or whether you use atorvastatin, there is still a substantial amount of residual risk. It's not as if treatment with a statin or an ACE inhibitor or an antiplatelet agent gets rid of all of that increased cardiovascular risk in our patients with type 2 diabetes. And indeed, it's not about the amount of LDL reduction either. I use a lot of PCSK9 monoclonal antibody treatments in my patients with type 2 diabetes and cardiovascular disease, or in my patients with familial hypercholesterolemia that we would all acknowledge are at high risk of cardiovascular events. And I'll combine that a lot with a statin to reduce LDL cholesterol very substantially. And I've been astonished over the course of the last decade that you've been using this combination of evolocumab or alasiramab as a PCSK9 monoclonal antibody with high dose statin. And I can put LDL cholesterol way down to 1 millimole per liter and below that. But there will be still substantial cardiovascular risk, still residual cardiovascular risk. And so what we know is that we can very powerfully affect LDL cholesterol as a recognized risk factor. We can very powerfully now affect treatments. We have treatments for very powerfully reducing blood pressure. And we have good antiplatelet agents, but these patients still have a lot of residual cardiovascular risk. So I'd like you now to think about metabolic dysfunction in terms of that residual cardiovascular risk. And ask yourself then, what's the consequences really of metabolically unhealthy obesity, particularly where that obesity is around the waist or central obesity, when it's associated with glucose intolerance or type 2 diabetes, when there's high blood pressure and high triglycerides, and when there's low HDL cholesterol. And these are the key features of metabolic dysfunction that we alighted upon from the George Alberti criteria from 2009, published in Circulation as the agreed harmonized criteria for diagnosing metabolic syndrome. And what George Alberti stated in that 2009 paper, in fact, I started my career really in undertaking research in metabolic syndrome in type 2 diabetes. George Alberti maintained that to diagnose metabolic syndrome, you needed 3 out of these 5 criteria. Now, to define metabolic dysfunction-associated steatotic liver disease, or MASLD, you need just 1 criteria. But we know from George Alberti's work on metabolic syndrome that it was 3 out of these 5 criteria that were needed to define metabolic syndrome. And George allotted on that with his colleagues in 2009, because when an individual had 3 or more out of these 5 criteria, that's where risk of cardiovascular disease really started to increase. And in fact, as far back as 2006, one of my research fellows for his thesis work published this paper with myself that we produced for Diabetologia that was published in 2009 and 2006, where we didn't specifically say, does a patient have fatty liver disease? I wasn't particularly interested in fatty liver disease back in 2006, but I was interested in knowing the impact of metabolic syndrome traits on risk of cardiovascular outcome and on all-cause mortality in our patients with type 2 diabetes. So seizing the opportunity of working with a colleague, Wendy Gatling, on the south coast here in Poole, Wendy had a community-based type 2 diabetes clinic where she recruited everybody to that clinic for lifestyle advice because they had a new diagnosis of type 2 diabetes. So all the primary care physicians at that time were referring in patients because they had a new diagnosis of type 2 diabetes to Wendy's clinic. And what Rustam, my research fellow, did was just counted numbers of features of metabolic syndrome that an individual had with type 2 diabetes at baseline. And we followed these people for 5 years as part of his thesis work. Now, he couldn't have drawn this and made it up any better. Here's individuals who've just got one feature of metabolic syndrome. This is their Kaplan-Meier survival curve out to 5 years. And that one feature of metabolic syndrome that they've got is type 2 diabetes that defined their referral to the clinic. Here's an individual who's now got 2 features. So type 2 diabetes plus another feature. Here's an individual with 3 features of metabolic syndrome, type 2 diabetes plus any other 2 of these 5 features, etc. 3, 4, 5 features of metabolic syndrome. Individuals in this group, and there were about 1,000 people in this particular study, so there were significant groups of individuals in all 5 categories. And here's the Kaplan-Meier survival curve if you had type 2 diabetes plus all other 4 criteria of metabolic syndrome. So you can see there is a cumulative impact here of the severity of metabolic dysfunction, which was my biggest fear in us enabling in 2023 a clinician to make a diagnosis of metabolic dysfunction associated steatotic liver disease, MASLD, on the basis of only 1 criteria for metabolic syndrome. What would happen if an individual presented with steatotic liver disease and had all of these features of metabolic dysfunction? And I'll come back to that in a moment. So with my great friend Giovanni Targia in 2015, we published this paper for Journal of Hepatology, proposing for the first time that MASLD, now as we now call it, is a multi-system disease. We looked at all of the data for this particular paper that had accumulated up to that time, some of which I'd produced with my colleagues in using the Korean database that they've got, a big occupational database, where we'd shown that NAFL was a risk factor, an independent risk factor for cardiovascular disease in that Korean cohort. And we'd shown that NAFL was an independent risk factor for developing type 2 diabetes. And here's a schematic from the figure where we proposed mechanisms that might be operating then, by which NAFL might increase risk of type 2 diabetes and cardiovascular disease. But the world's moved on since 2015, and we've been part of contributing a lot more data now, which I think firms up the notion that NAFL truly is a multi-system disease. And it's really important for clinicians, as I'm constantly saying here to my hepatology colleagues, to think about risk beyond the liver in looking after your patients with MASLD. So in 2023, we had the agreed criteria. that were produced. We had criteria for the first time for MASLD as well within those criteria that are particularly useful as well, I think, in helping identify those individuals who are consuming modest amounts of alcohol as well as having steatotic liver disease, but in whom we wouldn't say that they had true alcoholic liver disease. They're sitting in this sort of intermediate category where they're consuming modest amount of alcohol with other criteria for MASLD. And I think that's an interesting group to be thinking about, particularly for us in Europe, where people tend to be consuming alcohol along a normal distribution curve, rather than perhaps exist in the States, where alcohol consumption in the population tends to be bimodal, and people really from a predominantly religious background are complete and utter teetotalers, consuming no alcohol at all. And how we in Europe recognize that's quite an unusual phenomena, and people are consuming alcohol in the UK much more along a normal distribution curve. So I think for us in Europe, this category of MASLD is particularly useful. Now, we know that testing for liver disease is easy now in 2025 compared to perhaps 2015 when we published that article for the Journal of Hepatology. But our problem at the moment that I feel is that it's not accepted outside the hepatology community that it is cost effective to screen even high-risk groups, such as patients with type 2 diabetes, for evidence of liver fibrosis. And I think it's a real problem when you step outside the rarefied atmosphere of hepatology scientific meetings and hepatology guidelines and talk to people in primary care and talk to diabetologists. They have certainly not accepted that it is cost effective to screen even high-risk groups such as those with type 2 diabetes for evidence of liver fibrosis. And we're trying to address that at the moment in a big population within this trial on the South Coast that we're studying at the moment, where we've randomized individuals with type 2 diabetes to usual care, and we've randomized the other half to measurements with vibration-controlled transient elastography and with blood biomarker tests such as ELF test and FIB4 to identify whether individuals have high probability of having F2, F3, F4 fibrosis within the community. And the primary outcome of that study is really where hepatologists consider that an individual needs to be followed up within secondary care for HCC surveillance. We're coming to the end of that trial at the moment, and we'll be evaluating the cost effectiveness over the course of the next year in looking at the data in modeling with Markov modeling, which particular individuals with type 2 diabetes in whom it's likely to be cost effective. Because I don't really believe that it's going to be cost effective to screen everybody with type 2 diabetes for liver fibrosis. Because what you have to remember as hepatologists, a little old lady at the age of 70, 80, 90 may well develop type 2 diabetes tomorrow, but she may be thin. She may be having none of these features of the metabolic syndrome. She's simply developed type 2 diabetes with aging because her beta cells, she doesn't have enough of them, and the beta cell function is not good enough to maintain normal glucose tolerance. So she has a diagnosis of type 2 diabetes without any of these features of the metabolic syndrome, and aging is the major reason that she's gone on to develop type 2 diabetes. So I think what we're going to need to do for the future is look for the real subgroups within those people who have MASLD in trying to work out in whom it's going to be cost effective to say to our primary care physicians, this is the group essentially that you need to screen for liver fibrosis. So the nomenclature we've talked about, these were the original George Alberti criteria from 2009. And I show you this slide just to highlight to you, it's really important to think about ethnicity when you're thinking about waist circumference and BMI within these criteria for MASLD. There are different cutoffs according to ethnic group. So with Giovanni Targia and Alessandro Mantovani, we've produced very many what we think are high quality meta-analyses looking at various outcomes on the right-hand side here, work that's been driven forward by Giovanni Targia and Alessandro Mantovani that I've helped contributed to, where the outcomes have been, as I've shown you, CVD, cardiac failure, arrhythmias, type 2 diabetes, CKD, extrahepatic cancers. And in meta-analyses, what we've been doing is looking at the magnitude of the effect size by which steatotic liver disease, MASLD as we're calling it now, increases risk of these outcomes. And in various meta-regressions, what we've been trying to do is see where there is effect modification of other risk factors with the steatotic liver disease that modifies risk of these particular outcomes. But suffice it to say, what we now know is that NAFL, steatotic liver disease, is an independent risk factor for all of these outcomes on the right-hand side, increasing risk by up to about threefold maximum. And at minimum, for example, extrahepatic cancers, the risk increases of the magnitude of 20 to 50% increase for obesity-related cancers, essentially. And in a narrative review that we have accepted, working with Giovanni Targia, again, that's just hopefully will come out very, very shortly in the New England Journal. We're just at the proof stage at the moment, but what we've done within that review is we've quantified the magnitude of this increase in risk for these various outcomes. If you have liver fibrosis, as you would expect, then you really ramp up the increase of cirrhosis HCC. As I said, for CKD and for certain cancers, you're in the sort of territory of a 1.5-fold increase for these particular outcomes. NAFL is, if you haven't got type 2 diabetes yet, NAFL, as you might expect, because of that metabolic dysfunction, is a slightly stronger risk factor for incident or new type 2 diabetes than it is for cardiovascular disease and heart failure, where risk is about 1.5-fold increase. Again, this may change according to whether an individual has liver fibrosis with their MASLD rather than just simple steatosis. Now, working with my Korean collaborators over the course of the years, one of the things we've been very interested to know is if you make a diagnosis of NAFL, steatotic liver disease, and you haven't yet got type 2 diabetes, so you've not yet developed type 2 diabetes, with your NAFL, with your steatotic liver disease, does having NAFL, steatotic liver disease in other words, does that increase risk prediction for developing incident type 2 diabetes? So I, as a diabetologist, primary care physicians, will be aware of all the risk calculators that we can use that assign a level of risk for a patient developing type 2 diabetes. And what we didn't know until we produced this paper at the end of 2022 is we didn't know whether making a diagnosis of steatotic liver disease and adding that to the algorithms, the best algorithms that were available for predicting risk of type 2 diabetes, did knowing a patient have steatotic liver disease improve risk prediction for incident type 2 diabetes? Well, the message is yes, and I think that this is the first paper to show that a diagnosis of steatotic liver disease improves risk prediction over and above traditional risk factors for developing incident type 2 diabetes. And you can see if with the base here Here is the area under the curve, the receiver operator characteristic curve with traditional risk factors for type 2 diabetes. We used two different risk calculators here to do this, one from the UK and one from the US. And we added in a diagnosis of steatotic liver disease and looked to see whether we would improve risk prediction. Here's the improvement in risk prediction in premenopausal women. Here's the improvement in risk prediction in postmenopausal women, and here's the improvement in risk prediction for men. And so here's evidence, we think, for the very first time that NAFL adds to risk prediction for developing incident type 2 diabetes. And another important message to come out of this paper is if you make a diagnosis of NAFL in a premenopausal woman, compared to even a postmenopausal woman or a man, a diagnosis of NAFL in a premenopausal woman really ramps up that woman's risk of developing incident type 2 diabetes. So I think the way to think about this is NAFL really represents a manifestation of metabolically unhealthy obesity in most particular patients. If you're a premenopausal woman with this manifestation of metabolically unhealthy obesity, what NAFL is really doing in a premenopausal woman is really magnifying that premenopausal woman's risk of developing type 2 diabetes relative to a premenopausal woman that doesn't have NAFL. So I think, what you've got to think about here is context, and having NAFL as a premenopausal woman puts you at much higher risk relative to another woman than if you're a man with NAFL compared to another man without NAFL. So we know about these features of metabolic syndrome. Now you might ask the question of me, well, why are these features of metabolic syndrome? Why do I think that they're magnifying risk of cardiovascular disease? And I would respond to that by reminding you of very nice work that takes us right back to 1990 when I was doing my PhD. And in 1990, Melissa Austin and colleagues from the States published a very nice paper in Circulation where they looked at this cluster of an increase in triglyceride, a low level of HDL. So here are the two features of metabolic syndrome that they looked at. And what we don't measure in clinical practice, but what's strongly associated with having hypertriglyceridemia and a low HDL cholesterol is an increase in small, dense LDL cholesterol. And this cluster of 3 lipoprotein abnormalities, Melissa Austin and colleagues described as the atherogenic lipoprotein phenotype. And they showed in that paper in Circulation that this is a particularly atherogenic lipoprotein phenotype that magnifies risk of cardiovascular disease. So I put it to you, this is absolutely the lipoprotein abnormality that occurs in MASLD. We never measure small dense LDL, but I promise you, if you've got modest hypertriglyceridemia with a low HDL cholesterol, you will have an increase in small dense LDL. And this is a particularly atherogenic form of LDL. There isn't terribly much of this relative to the more buoyant LDL that comprises the estimated LDL cholesterol that I'd be interested in the lipid clinic that I run. But there is a significant proportion of small dense LDL in all of us, and in patients with MASLD, that proportion is even greater when patients have this high triglyceride, low HDL phenotype. Now, it's noteworthy, and we've known for a few years now that certain genotypes that you'll all be familiar with as hepatologists, PNPLA3I148M, TM6SF2, E167K, these particular 2 genotypes attenuate the hypertriglyceridemia that you get with MASLD. And they do that probably because they're affecting the VLDL particle. And normally patients with NAFL, if they've got the more metabolic form of MASLD, they'll have modest hypertriglyceridemia, And what you see with these two genotypes that worsen risk of liver outcomes but attenuate risk of cardiovascular disease is you see lower levels of fasting triglyceride, and fasting triglyceride is VLDL coming out of the liver. So in the fasted state, our fasting triglycerides, your or mine fasting triglyceride in the fasting state will be VLDL, very low density lipoprotein. And what these two genotypes do is, because of what they're doing with VLDL assembly, they lower that level of VLDL. They lower that fasting triglyceride. So I'd suggest to you, and some of this is proven, but not all of this, I'd suggest to you that this more genetic form of MASLD, made worse by having these particular genotypes, attenuates the impact of this, ameliorates it, makes it a little bit better, and thereby I'd suggest to you reduces risk of cardiovascular disease in that subgroup of your patients with MASLD who have the more genetic phenotype that's contributed to their MASLD. And some data to support my assertion comes from the UK Biobank cohort, where the investigators here, this study was nothing to do with MASLD at all. All the investigators did in this paper published in 2023 was used the 500,000 people within the UK biobanks where they had lipoprotein characteristics and incident coronary heart disease events within this prospective cohort. They identified 90,000 individuals in UK Biobank where they had both measurements of lipoprotein characteristics and incident CHD. And as you can see from the hazard ratios here on the y-axis and the VLDL concentration on the x-axis, as VLDL, aka fasting triglyceride, increases within UK Biobank, here's the hazard ratio for incident new CHD events. And as you would expect, what they proved for LDL cholesterol, which you and I would both accept is a recognized traditional cardiovascular risk factor, here's the expected increase in LDL cholesterol with CHD events. So here is very good evidence that VLDL is really important from a very recent study in UK Biobank, where, as I said, these investigators were not interested in MASLD at all. They were simply looking at this relationship between VLDL and CHD events. And if you bear in mind that our patients with MASLD are right up here rather than right down here, and they have a low HDL cholesterol, and they have an increase in small dense LDL, which is recognized to increase their cardiovascular risk, I'd suggest to you that this is part of a major mechanism by which our patients with MASLD are suffering that increase in cardiovascular disease risk. So in thinking about MASLD as a multi-system disease, we put this together with Herbert Tilg recently for a publication in Lancet Gastroenterology and Hepatol. And what you can see in thinking about NAFL or MASLD and type 2 diabetes is I've put on the slide here the increase in risk that has come out of our meta-analysis with Giovanni Tarja and Alessandro. And I've put on here what we know about how much type 2 diabetes increases risk of NASH, fibrosis, and cirrhosis on the bottom of the slide here. And so you can see, if we start with a patient in the clinic who has NAFL, steatotic liver disease, and hasn't yet developed type 2 diabetes, this is the magnitude of their increase in risk. Once they've got type 2 diabetes with their NAFL, this is what having type 2 diabetes does to them, developing increased risk of fibrosis and going on to cirrhosis. And so you can see you've got a vicious spiral operating here by which that patient with NAFL developing type 2 diabetes, once the type 2 diabetes is present, it's going to worsen the liver disease. And spinning off that spiral then, what we know from the meta-analysis with Gio and Alessandro is that this is the magnitude of the increase in risk of cardiovascular disease and CKD. And this is what I, as a diabetologist, with my diabetology colleagues, have known for many years about type 2 diabetes being a well-recognized risk factor here for CVD and CKD. So we've got this multi-system disease operating, I'd argue, with metabolic syndrome, metabolic dysfunction, and type 2 diabetes at the heart of it, with steatotic liver disease. And spinning off this spiral, we've got risk of CVD, CKD on the one side and the same on the other side. So that's really important. And the reason I put this schematic together for this narrative review that we wrote was to get people to focus on potential targets then for treatment in tackling MASLD as a multi-system disease. And so what we can do then with all these negative signs is intervene at all of these points. And we may need, I would argue, to intervene at all of these particular points. And I'll come back to that right at the end. So let's move on to some of the published and the unpublished work then from UK Biobank. And here, as I said, we were interested in the impact then of the severity of this metabolic dysfunction as you go from 0 traits, one trait, one metabolic syndrome trait that would allow you to define and assign a diagnosis of MASLD, all the way up to having all 5 of those metabolic syndrome traits. And what we were interested in were all of these particular outcomes, and how did having various numbers of these traits impact on risk of these particular outcomes. So our aim in the first of these studies then was to look at the effect of metabolic dysfunction in patients with steatotic liver disease on all-cause mortality and multiple hepatic and extrahepatic outcomes. So UK Biobank, to remind you, is a study of about 500,000 UK individuals recruited and participated between 2006 and 2010, very well characterized, who underwent a physical examination at baseline. Multi-organ imaging was undertaken in a subset. And 2 things are important to stress to you about UK Biobank when you get sent papers to review that have used UK Biobank. And there are an awful lot coming from China at the moment because you can buy access to this particular data. And it's not cheap, but people are buying access to the data from all around the world. Now, the 2 things that are really important to remember is they were not fasted blood tests that were taken. Now, that's important for lots of different measurements because there is a data field in UK Biobank that tells you the timing of when the blood sample was taken relative to participants to the last meal. So patients declared when their last meal was, and in UK Biobank, they've got an indication of how much time had elapsed from the blood sampling from that last meal. And it can be as little as 0 time virtually, all the way up to about 15 hours within that data field. So the samples were not truly fasted. The other really important thing to remember about UK Biobank is the imaging that was undertaken within UK Biobank was not contemporaneous with the timing of the baseline blood measurements. So when patients first participated, they had a blood sample taken. It wasn't necessarily fasting at all. It wasn't fasting in a substantial number of individuals. And then individuals were called back over time for things like an MRI scan that was undertaken in a subgroup. And in some individuals, that MRI scan could have been undertaken up to as much as 10 years after their initial baseline measurements. So that can be a problem in analyzing the MRI data as well, because additionally, there are not successive blood samplings done from baseline to follow-up. You've only got access to baseline blood measurements, imaging that was undertaken sometime between baseline and follow-up. But there is good linkage to electronic health records, so you can gain access to a whole range of important outcomes that we would all be interested in as researchers and as clinicians. At the time of analysis, mortality and hospital admission data for this particular data analysis I'm going to show you was censored to January 2023, and they're updating this every few months. And according to when you dip in to look at the data, then you can choose a later date or the closest date to when you start to analyze the data. So what we did here, bear in mind what I've said to you about fasting measurements not being available in all individuals. So you'll remember that in terms of the imaging, I said to you that was only available after baseline in some individuals. And so unfortunately, there are no good imaging data available at baseline to say whether an individual has fatty liver disease or not. You can't really, I would argue, be certain if you use the fatty liver index as a measure of hepatic steatosis, because remember, in the fatty liver index, you've got fasting triglyceride measurements, and triglyceride is something that is very much affected by when your last meal was, and it will be very much affected if that last meal contained a lot of fat. So I would argue you can't use the fatty liver index within UK Biobank, but what you can use is the modified hepatic steatosis index, which is reasonably well validated as well for steatosis. And what we did to be absolutely certain, bearing in mind that traditionally people have used a cutoff of 36 on the hepatic steatosis index, we decided that we would remove individuals in the intermediate grey zone, and we would go to a threshold of less than 30 to be sure people didn't have or had a low probability of having fatty liver disease. And we went to those individuals above 36 to be reasonably sure that they did have steatotic liver disease. And we just excluded individuals in the grey zone area between 30 and 36. So we defined whether an individual had steatotic liver disease using the HSI, and then used the FIB4 in the way that we're all familiar with, working in this particular area, to assign probability of risk for advanced liver fibrosis. We use the inclusion and exclusion criteria then for metabolic dysfunction based upon the criteria that I've shown you. And we excluded here individuals that would fit into the MASLD character for this particular first analysis. So here were our outcomes. And we looked first of all at CKD and incident end-stage renal disease, ESRD. So we did a cross-sectional analysis of CKD, and then in the smaller numbers where we had incident end-stage renal disease as the outcome, we did a prospective analysis for that particular cohort here. For MACE, for MARLO, so major adverse cardiovascular events as defined here, and MARLO as defined here, we used just incident follow-up. So we had incident MACE events, incident MARLO events, and similarly incident or new obesity-related cancers. And these are the ones that we were particularly interested in that came out of our meta-analysis with Gio and Alessandro. So first of all, focusing on CKD and end-stage renal disease. We define CKD as CKD stage 3 or worse, according to these criteria, and incidence end-stage renal disease using the UK Biobank validated algorithm that's been used and published for end-stage renal disease. And that work here we published at the beginning of 2025 for end-stage renal disease and for CKD. Here was the study design with a sensitivity analysis, cross-sectional study for CKD as the outcome, and a prospective study design for incident end-stage renal disease. We're using Cox regression here. So again, just to remind you, without SLD, your HSI had to be less than 30. With SLD, your HSI had to be 36 or above. And we excluded individuals in the middle because we couldn't be certain that there would be misclassification bias in that middle group. We got 102,000 people in this group, 34,000 in that group. Here were the criteria according to their metabolic syndrome criteria, very much as you would expect for all the different criteria. For metabolic syndrome, as defined by 3 or more of those metabolic dysfunction traits, there were reasonable numbers, even in the group without steatotic liver disease here. And almost 2/3 of those with steatotic liver disease had 3 or more of the metabolic syndrome criteria. So here's the data looking on the left-hand side then at numbers of traits for metabolic syndrome from no trait at all the way up to 5 traits. The reference group was no steatotic liver disease and no metabolic syndrome traits here. And you can see as the number of traits increase for metabolic syndrome, here's the odds ratio for having CKD. This was a sensitivity analysis here. You'll notice the N is much smaller. This was a sensitivity analysis in panel B, where we looked at that subsection who had imaging data that we could use to say whether they had fatty liver disease according to this MRI threshold that's well published from the Dallas Heart Study, to say whether an individual had steatotic liver disease. The curve looks pretty much the same, as you can see. And the caveat is for panel B, remember, is that the imaging was not contemporaneous from the timing of when the metabolic syndrome traits were defined. That said, with that caveat in mind, you can still see there's a very similar curve there using MRI as the gold standard. So looking for incident end-stage renal disease now on the right-hand side, and on the left-hand side, prevalent CKD, looking at the amplification with high risk of advanced liver fibrosis using the FIB-4 score. And you can see here that if you had metabolic syndrome, 3 criteria or more, with evidence of advanced fibrosis, of high probability of advanced fibrosis defined by FIB-4. Here was your adjusted odds ratio for prevalent CKD. So advanced liver fibrosis plus metabolic syndrome is not good news. And on the incident end-stage renal disease, with a prospective study design, we had to look at just metabolic syndrome versus no metabolic syndrome here, because there weren't enough of individuals in the individual subgroups with 1 trait, 2 traits, 3 traits, 4 traits, 5 traits, etc. So we just looked at 3 or more traits, i.e. metabolic syndrome, versus less than 3 traits, no metabolic syndrome with SLD. And you can see again, you get the same effect here in the prospective analysis for risk of incident end-stage renal disease. So moving on now to Marlow, MACE and obesity-related cancers. And this has been submitted as an invited resubmission to Metabolism after the reviewers asked us to do a bit of work, and hopefully it'll be accepted very soon. We did exactly the same analysis for Marlow, MACE and obesity-related cancers here. And you can see, just look at the data here for Marlow, as you go from no traits all the way up to 5 traits here. This is the fully adjusted model. The hazard ratios here adjusted for these particular covariates and confounders here. You can see this striking increase in risk of Marlow as the number of metabolic syndrome traits increases here. So we think having the severity and us as clinicians assessing the severity of that metabolic dysfunction, which is now easy to do with these George Alberti criteria for metabolic syndrome that we can all use in the clinic, we should be, we would argue, starting to say to a patient, not you have MASLD, but you've got MASLD and you've got all 5 of these metabolic syndrome traits with your steatotic liver disease. And we now know that that's going to further increase your risk of developing major adverse liver outcomes, according to this particular analysis. We did the same for MACE. We did the same for obesity-related cancers. Here I show you the data for metabolic syndrome. Remember, that's 3 of the criteria. We did the analysis with MASLD as well, rather in this particular analysis, and not just with MASLD. And we can see exactly the same sort of impact with MASLD. Here's the Marlowe outcomes up here for MASLD. Here's the MASLD MACE outcomes here. There's the adjusted hazard ratio for MASLD with metabolic syndrome, and very similar data, albeit with a weaker signal for obesity-related cancers as well here. Here's the all-cause mortality data here now for those with MASLD, followed for about, the follow-up is about 14 years maximum in individuals. And what's shown on the cumulative incidence graph here in the different colors is here's all of the different features of metabolic dysfunction. So here's all 5 features of metabolic dysfunction, and here's your risk of dying, cumulative incidence for all-cause mortality with all 5 of those features of metabolic syndrome, versus if you've only got 1 feature of metabolic syndrome here, this is the minimum criteria for defining MASLD. You can see most of these patients are still alive at 14 years follow-up. So again, the all-cause mortality data looks like the incident outcome data, and we think it's really important to measure, first of all, these different features of metabolic syndrome in our patients in clinic. So that's really what this slide shares. This slide says in terms of our future assessment and management and surveillance of MASLD, we would argue it's really important to start to measure these in the clinic because the number of these traits is important. We would all, as researchers and hepatologists working in this field, we would all acknowledge it's important to assess the severity of liver fibrosis. And for the future, I think it will be really important to think about genetic susceptibility, particularly with response to PNPLA3, and maybe also TM6SF2, because that does seem to attenuate risk of cardiovascular outcomes as well. So coming back to this schematic that I showed you now, I've now put treatments on this particular slide. And I think it's really important to be thinking about incretin receptor agonists. So we're thinking about semaglutide, we're thinking about tirzepatide. If you have any concerns about safety for GLP-1 receptor agonists in particular, bear in mind that people like I have been using them for 20 years in the clinic to treat patients with type 2 diabetes since the first licensing of exenatide in 2005. And yes, they do cause GI side effects in some patients where they can't tolerate them, but both GLP-1 receptor agonists and GIP receptor agonists are extremely well tolerated. I would argue in the right selected patient, I haven't had time to show you the data, but pioglitazone in the right patient where it's not contraindicated, that can be useful because it helps you treat cardiovascular disease. The meta-analysis shows that it attenuates cardiovascular events and there is a benefit on liver disease. So you've got a benefit with pioglitazone on glucose control, a benefit on incident cardiovascular events, and a recognized benefit in MASLD as well. And SGLT2 inhibitors really important for CKD risk and for CVD risk. There may be a benefit of SGLT2 inhibitors in liver disease, but the jury is still out there. And we've published some of that with our Korean collaborators, which does suggest that SGLT2 inhibitors have a benefit on liver outcomes. Statins attenuate cardiovascular risks. They're probably pretty neutral with respect to liver disease. And similarly for ACE inhibitors or ARBs, you're treating hypertension very effectively. You're treating risk of cardiovascular disease, and you're treating risk of CKD. And you'll all be familiar with resmetirom as a thyroid hormone beta receptor agonist. I think it's going to be far too expensive for all of us to use in Europe, unless the price comes down pretty quickly. But at least theoretically, in terms of the mechanisms, it's got all of us working in this field as endocrinologists thinking about the benefit of T3 metabolism and thyroid hormone receptor beta agonists, because remember, that particular receptor is only expressed in liver, unlike thyroid hormone receptor alpha, which is expressed ubiquitously. And it's that alpha that T3 binds to that would increase your heart rate, for example. It seems that resmetirom, acting on the beta receptor agonist specific only to the liver, doesn't have that side effect of increasing heart rate that bedevils treatment with T3, for example. So probably, I think I'll probably pass over this to, this is just a little bit. I'm going to be talking about this at the ADA, the American Diabetes Association in June. But I think I'll pass over it and move on to this particular slide to get us all thinking about, we've now got treatments on the horizon. How should we be monitoring treatment responses? Because you'll all be familiar with the fact that not every patient benefits. Yes, resmetirom, yes, semaglutide in essence met their primary outcome, but not every patient benefited. And there are going to be patients in whom we're going to have to say to this patient, you've not responded, therefore, I'm terribly sorry, Mrs. Jones, but we're going to have to withdraw this treatment. We're going to have to decide as a group how long we use the treatment for. And we're going to have to decide as a group, what particular non-invasive tests should we be using, because it's going to be completely impractical and probably unethical to rebiopsy patients to decide whether they've responded to that expensive treatment. So how should we be monitoring that response to say to a patient, you're getting better, or to say to a patient, this expensive treatment is not benefiting you as an individual? And I think this is going to come down to, I would argue, to ELF testing plus vibration-controlled transient elastography. I don't think FIB4 is particularly useful compared to, for example, ELF, but more data is definitely needed. And I think it's probably going to end up, for those of us that don't have access to magnetic resonance elastography, because our hardware and our hospital scanners doesn't have the additional magnet, at least at the moment. So we in Southampton don't have access to MRE. How are we going to be monitoring treatment responses? And I think it's going to come down to probably ELF plus vibration-controlled transient elastography, in my particular opinion. We need to be thinking about monitoring safety as well, and we need to be thinking about how frequently should we be repeating these tests. With resmetirom, if ever you have access to it in Italy, do be thinking about drug interactions. Don't forget that resmetirom is metabolized by a cytochrome P450 system that is also an important system for metabolizing other drugs that patient with cardiovascular disease or at risk of cardiovascular disease may be already taking. For example, clopidogrel, for example, resmetirom and rosuvastatin might be a problem, and resmetirom and pioglitazone, where drug levels increase by 1.5 times. So it is very important to be thinking about the dose that the patient's on, and probably there are going to be maximum statin doses in your patient that you'll decide to treat with resmetirom. So we need to agree when we should stop these expensive treatments. We need to agree it's a potentially beneficial response, and we need to agree that the benefit is uncertain, and maybe we need to reevaluate treatment or even stop treatment for the future. So in conclusion, MASLD, I'd argue, affords lots of opportunities and challenges for clinical practice and research. And for those of you that are younger working in this field and thinking about an area of research, I'd strongly encourage you to think about undertaking research for a higher degree in this particular area, because there are lots of opportunities, lots of questions still to be answered, and lots of challenges for the future. MASLD is a multi-system disease. I hope I've convinced you of that. It frequently occurs in patients with type 2 diabetes, and I hope I've convinced you that the severity of that metabolic dysfunction is very, very important, and we as clinicians need to be starting to thinking about evaluating the severity of that metabolic dysfunction in our patients in the clinic. Residual cardiovascular disease risk still exists in our patients with type 2 diabetes, even after we've reduced LDL cholesterol. And I'd suggest to you it may be VLDL, low HDL cholesterol, and increased small dense LDL cholesterol that might be contributing to that increase in risk in our patients with MASLD. Repurposing licensed treatments such as the incretin receptor agonist is going to offer real promise. I think what will happen with this class of drugs for the future is many of them will go off patent pretty quickly. The drug manufacturers are falling over themselves. The price will come down. Many particular manufacturers are getting into this space, and the utility of incretin receptor agonists is going to be very considerable for us working on MASLD as a multi-system disease for the future. So tons and tons of people to acknowledge, as well as our funding bodies, as well as I'd particularly like to draw attention to all of my international collaborators over very many years, and in particular a sad opportunity to remember my close friend and colleague Valerio Nobili from the Bambino Gesù Hospital in Rome, when we were doing some very exciting work in pediatric NAFL, sadly just before his sad loss in 2019 with a tragic cycling accident in Rome. That was particularly insightful for me, just thinking about this presentation and what I was going to say to you, because just 10 days ago, I had a very bad cycling accident, and it's perhaps just as well you can't see me on this slide, because I've got some very nasty injuries on one side of my face from that cycling accident. But I'm slowly recovering, and sadly, Valerie lost his life in that tragic accident. So thank you very much for listening, and thank you too for giving me this opportunity, and I hope you've enjoyed it as much as I have in giving it to you.